And welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
This week on Research Works, we have the lead author of the paper recently published in Developmental Medicine and Child Neurology titled Task-Specific Training for Bicycle Riding Goals in Ambulant Children with Cerebral Palsy, a randomized controlled trial. Welcome, Dr. Rachel Toovey.
Welcome.
Hi, guys. Thank you for having me here. It's exciting to talk with you about this paper.
Oh, thank you so much for being on the show. First up, though, we have to congratulate you on receiving your PhD.
Hooray!
What a huge amount of work, but really important work to add to our growing knowledge base on interventions for children with cerebral palsy.
Absolutely. We know that intervention studies in the area of cerebral palsy really do reflect a huge amount of work, blood, sweat, and often tears. So, the really exciting thing about your paper, Rachel, is the real world applications. And I know that a lot of our listeners will really benefit from hearing from you about this paper today. So why don't we start by properly introducing all of our listeners to Rachel. Rachel is a physiotherapist and a researcher. She's a lecturer with the Department of Physiotherapy at the University of Melbourne. Rachel's work really reflects her broad clinical interests across the areas of paediatrics, disability, health equity, motor learning, Indigenous health, and inclusive sport participation. Rachel has contributed to the development and implementation of a statewide model for hip surveillance in cerebral palsy with the Centre of Research Excellence in CP at the Murdoch Children's Research Institute, and as the coordinator of the Bike Skills program at the Victorian Paediatric Rehabilitation Service at Monash Children's Hospital. Rachel has presented her work at various international and national conferences and published in peer-reviewed journals, and we're so lucky to talk to her about this recent publication today.
Oh, what a great introduction. And I think, look, the last time I spoke with Rachel was only just a few weeks ago. And firstly, I must say, I was really impressed by her ability to multitask, which I think a lot of parents have fine-tuned these skills now with lockdowns. And you're a part of some really exciting things as well, Rachel. Like, just congratulations to all of the things that you're a part of. Huge well done.
Mm-hmm. Thank you. Thank you very much, guys.
So, Rachel, we like to start our episodes off with a little icebreaker question so that we can get to know you and you can get to know us and all of our listeners can get to know everyone a little bit better. So our question today is, do you have any hidden talents?
Ooh.
Well, actually, the work that I've been doing in my PhD was really sparked about 15 years ago when I did training to become a tennis coach.
Oh,
that's
cool.
Probably my little hidden talent is that I'm a tennis coach. Well, I haven't coached tennis for probably about 8 or 9 years, but really learning about skill acquisition and motor learning in the context of tennis really got me interested in this. And then I was able to apply some of those learnings in my work as a physio and noticed a big gap when it came to bike riding. So that was one of the things that inspired me to go on the journey, what was it, about 4-year journey in the end to work on my PhD and this trial that we're talking about today.
I love that your hidden talent has also been wrapped up in what we're talking about today. So bonus points for that.
Yeah, that's very cool. Very cool. Ash, what about you? What's your hidden talent?
Okay, my hidden talent, I have a really good memory, but not for anything that is of use to me in my work or everyday life. So I could recite to you all of the lyrics to a stupid song from like 1994, but if someone asked me what I did yesterday, I can't remember. So I wouldn't say that it's a useful talent.
Still a talent, nonetheless. I think when you want to sing, rave out those songs from the 90s, which are the best, you'll be like right at the front and center. Yeah. So that's really cool.
Oh, God. Yeah, watch out on karaoke nights.
Yeah. And other useless information as well, like useless movie quotes, just, really,
Love it. I actually really love it. Look, okay, so my hidden talent is a little bit different. It's to do with music. It's probably a combination of the two of you. So I love music and I don't have perfect pitch. I wish I did, but I've got relative pitch. But I taught myself how to have relative pitch because I play out music on my teeth. So if I'm hearing songs or I'm hearing music, I can work out what notes they all are by like tapping it out on my teeth.
What?
So if you ever hear me listen to something and you sort of see me sort of playing around my mouth a little bit, sort of my tongue's poking about, it's because I'm just working out the lines to the song and it's very, very accurate. So the tip of my tongue usually will be playing around with my teeth, and I know this is a podcast, you can't see me, but down here is a G, right here is a C, right up there's an octave up to the C. I've got sharps and flats, everything in there.
What?
It's weird.
Oh, I'm so testing that.
So your mouth is like your teeth are a musical instrument.
Very much so. Phenomenal. Sometimes I go to bed with a really sore jaw and I'm like, man, I must have been transcribing a lot of music today.
I so wish we could test that on the podcast, but we can't. So,
Dana, cool talent.
Yeah, absolutely. Why don't you take a break from that to talk us through the specifics of Rachel's paper?
All right, focus. All right, so this paper involves 62 ambulant children with cerebral palsy aged between 6 and 15 years, so 33 males and 29 females, with a mean age of 9 years and 6 months. Now, these children participated in either a task-specific group-participated physiotherapy-led group-based intensive training program. And this comprised of 2-hour sessions over 3 consecutive days at an outdoor park and 30 minutes of daily home practice for the remaining 4 days. So this made 1 week of intervention. Now, this group was then compared to another group, which was a parent-led home group program where parents were encouraged to work towards their child's bike riding goals 30 to 45 minutes each day over the 1 week. So this was an assessor-blinded, parallel group, 1-to-1 randomized controlled superiority trial conducted across 2 sites of the Victorian Paediatric Rehabilitation Service. The primary outcome measure was the Goal Attainment Scale, which was assessed after 1 week of the intervention and then again at 3 months after the intervention. The results indicated that children in the task-specific training group had greater odds of goal attainment than those in the parent-led home program at 1 week after the intervention, with evidence of superiority retained at 3 months.
Oh, this is so interesting. I'm so excited to get into this with you, Rachel. But before we do that, I like to ask a little question around study design. And so I was hoping that you might be able to explain to our listeners what an assessor-blinded parallel group 1-to-1 randomized control superiority trial actually is.
No problem. And I think it's it sounds complex, but it's probably a little more simple than it sounds. And so I'll just break it down by each component when describing it. And we'll start off with the randomized control bit, which is really testing 2 different programs. So we had an intervention program, which was the task-specific program, compared to our control program, which was the parent-led home program. Yep. And people were randomly allocated into each of those programs. So the participants didn't get a choice, just a bit like flipping a coin into either program. When we talk about the superiority part of that, we were interested in whether one of the programs, so our intervention program, the task-specific one, was better or superior to the other program. Right. So that was important in defining and linking it back to the research question of whether it was better than, not that it was as effective as, or if they were adding a component was. We were really interested in looking at whether the task-specific one was superior to. And then if we work back in terms of the other components of it, the 1-to-1, that means that there was just the same number of children and participants in either group. So we had we tried to split it. Well, it was split as evenly as possible as randomization would allow, and we ended up with 31 in each group. Yep. With the parallel group, that just means that they're happening at the same time. So we ended up having between 6 to 10 children come in at a cohort at the one time, because we had 3 to 5 children in the group. So we had these kind of cohorts of participants that came through at a time, and then around half of them got allocated to the the group-based task-specific program, and the other half were allocated to the parent-led program. So we did it over about 5 different school holiday periods.
Oh, wow.
And then when we think about the assessor-blinded part, that is the assessor, so the people that are looking at the outcome measures, they were blind to which group the children were allocated to.
Yeah.
So they weren't aware to reduce any bias that could come in by knowing that the children may have been in one group, so to expect better results or just based on what their own personal hypothesis might be.
Yeah.
And so we could only blind the assessors in this trial. Some other trials blind the participants and the interventionists, but we were only able to blind it given the nature of this study.
And could you just explain to us how you arrived at your, I suppose, control condition?
Yeah.
So the parent-led
control group. Yeah. So the parent-led home program was based on. It was a really difficult thing to define, and I think a lot of studies. It's one of those things that you don't see really in the literature about how hard it is to work out what the control intervention is, because usual care is often actually such a mix of different things.
It's so different for everyone.
Not one random thing, not one, really uniform thing. So what we actually had done was the second study in my PhD, so this was the third, but the second study we did was a current practice survey where we we surveyed people from and physios and OTs from all across Australia, and we looked at what physios and OTs were doing in terms of bike riding training and if they were doing it. And what we found was that it was actually really quite random, and there was quite a few participants in that study, so the physios and OTs, that weren't confident and hadn't necessarily been doing any bike skills training or working towards bike riding goals. And we'd also done another study in the past which was looking at skill acquisition, in which we surveyed parents, and many parents had actually said that of those kids that had learnt, that they actually had taught them at home and they didn't have any specialist support from physios and OTs because they weren't aware that that might be something that they could do. So with those 2 studies, we sort of looked at that evidence that we had and decided that this control group was really probably most likely to be and something that we could control was this parent-led program, because we'd seen that those children in the past had been working with their parents at home, much like typically developing kids. That's the main way that many typically developing kids had learnt. So that's why we chose that group. And then what we tried to do in terms of the actual components of that intervention was match it in terms of dose with the task-specific program.
Sure. And I guess it was quite reflective to look at that in terms of the control group and what does happen from there.
Yeah.
So now just going a little bit into you sort of touched on it a little bit there as well. So children with cerebral palsy, I know your population here was GMFS level 1 and 2. So you've had a bit of a look about their mobility and bike riding. Can you just summarise a little bit about what we currently know about bike riding status for children with cerebral palsy?
Yeah, so that comes back to actually the first study that I did in this area, which was a survey of families of over 100 families with kids with cerebral palsy, and then families of children that were typically developing, and we looked at skill acquisition, so whether those families or those children had learnt to ride, and also what age they had learnt to ride. And we found, not surprisingly, quite a big gap in the difference between the two. There were some children that had learnt to ride, particularly those classified GMFCS level 1, but overall there was quite a gap between those children that were typically developing and those with cerebral palsy in terms of if they had learnt to ride. Not only the proportion who had ever learnt to ride, but also the age at which they had learnt to ride. Wow, so for kids that were typically developing, that was around 5 years old. And for the roughly 50% of kids that had CP that had learnt to ride, and they were GMFCS level 2, they had learnt at a median age of around just over 10 and a half. So between 10 and a half and 11 they learned. So it's quite a difference in the age that they had learnt to ride.
Yeah.
Yeah. And I guess in terms of why it's important, I mean, obviously we know that children are learned to ride quite early. You said, 5 years of age. But why is it an important skill for us to consider in terms of things that we should be teaching and supporting our children with cerebral palsy?
Well, first, I think that it's a goal that the reason that I pursued this work from that very first survey that I was talking about when we looked at skill acquisition was we had families coming to the clinic that I was working with the Victorian Paediatric Rehab Service wanting to learn to ride and asking if it was possible. And when we looked at the literature in cerebral palsy, there was such a gap in this area specific to bike riding. So that was sort of why I went down this path. And to come back to your question about why it's important, I think it's because it's actually a meaningful goal and it's a really common, popular childhood activity that it's almost like a bit of a rite of passage to learn to ride a two-wheel bike for those children that are ambulant. I'll touch on it a bit later, I'm sure, but, looking at other forms of cycling is really important as well in terms of adapted bikes for those kids that might not be appropriate for a two-wheel bike too.
I mean, it's so powerful, isn't it, Ash? I can remember when I first learned how to ride a bike and all the falls and having my dad teach me, and it's one of those things that you do remember quite fondly, and you're right, like in terms of like a rite of passage, it's one of those things that you go, I did that, I can do that, and it's a lifelong skill.
Yeah. And especially when you're thinking about, typically developing children are starting to pick this skill up around 5 years of age, whereas, if our children with cerebral palsy aren't able to do that until 10 and a bit later, that's such a huge developmental period that they're kind of missing out on that opportunity to socialise and be active with their friends and their siblings.
That's right.
Yeah,
it's huge.
All of those things. So, Rachel, with regards to your study, the assessments that you used, I'm hoping we could talk about those in a bit more detail now. Your primary outcome that you were focused on was the Goal Attainment Scale. And we noticed that you had a -3 value in your scale, and that was related to deterioration of the skill. So could you just explain to us why you added that in?
Yeah, sure. So we added that in based on some of the work that had been done in the Netherlands by I think it was a medical doctor who did a PhD on the Goal Attainment Scale in paediatric rehab, and he looked at Steenbeek, his name is, and he looked at the Goal Attainment Scale and its use, particularly in paediatrics and rehabilitation, working with kids like we had in our studies with cerebral palsy, and that one of the missing components of it in his evaluation was this deterioration, because prior to it just started at equal to the beginning. But in fact, there is a possibility that if someone hasn't practiced the skill or hasn't been able to be in a supportive environment, then they might deteriorate and might not do it. So that we did that because we thought that was fit for purpose and really practical for looking at our activity and participation goals, compared to some of the other uses that it had been in the past where maybe you might not expect deterioration, but we thought that was a really important component to capture.
Yeah, for sure. And you just touched on there on your activity and your participation goals and this distinction between the two. Could you just explain to us and the listeners what the difference between an activity goal and a participation goal might be?
Yeah, sure. So it really comes down to looking at the ICF framework and applying that framework to the goal setting. So when we're thinking about activity, it's really the execution of a task, or probably looking more at the skill on its own. So that might be, for example, being able to ride in a straight line on your own for 50 metres, for example. That's an activity goal, but that's different to what a participation goal is. And there's been a lot of work done in this area, as you both know, around how it's not only about attending as part of participation, but the involvement. So, and not only just about the frequency of participation but also how much the child is engaged in that.
Right.
So, for example, with a participation goal, some of the children came that they might have made were things like participating in bike riding on school camp. There's like many, I'm not sure in Perth, but in Victoria, many school camps have bike riding as a component. So being able to participate with their peers in the school camp program, or doing things like going on family bike rides, or going to participating in the bike ed programs at school, or even things like going on school holidays to caravan parks and being able to ride around with their peers. So it's thinking about the application of those skills in the real world in a context.
So important.
In a life situation. So those are obviously really meaningful goals as well.
For sure. And there's a really beautiful table in your paper that explains that as well when people go to read that. So thank you for explaining it to us. Some of the other assessments that you used around your secondary outcomes include the physical activity questionnaire score. Could you just give us a little a summary of what that is and what it measures?
Yeah, so that one is a very basic score that collects information around, and it's actually completed by the parent, and it looks at the different types of activities that a child might be participating in during the week, and also then how often. And so based on the different types of activities that the child is doing, it creates a score that then can be compared. We looked at that at the immediately after the program, and then at the 3 month later mark. But because it was a score that was completed by the parents, and it's quite a sort of crude measurement, it's not like a diary. We also did the actigraphy and looked at accelerometry. So we the participants wore a accelerometer at baseline, and then again at 3 months later, because we thought that was a more reliable way of looking at physical activity. Yeah,
a bit more objective in terms of the information that you're collecting.
Yes, yeah.
So now into the nuts and bolts of the actual intervention itself, which I'm really excited to talk about. So the physiotherapy-led group, what were the main features? Like how is it that as physiotherapists you can teach the skill of bike riding?
Yeah, sure. So I think first of all I'll talk a little bit about the structure of the session, because I think that it's not just the actual direction or that the coaching or the therapy to the and interacting with the child and the parent themselves that makes a difference. It's kind of a kind of a complement of different ingredients. So the intervention was obviously task specific, really focused on bike riding, and was underpinned by motor learning theory. But we also it was also goal directed. So the goals that the children set were at the beginning were available, and the therapists that were running the training programs were aware of those goals and worked specifically on those goals. It was also important that it was led by a physiotherapist. So each group had a lead physiotherapist and then an allied health assistant that supported it. And another component that we thought was really important was that parents participated as well. So it wasn't that the children were dropped off at the program and then the parents left. The parents actually participated as much as they were able to. And that only that not only helped with the manual aspects of bike riding, because it is a physical activity that requires some manual support at times, but it also meant that the parents were able to then work with their kids and have an idea about what to do with their kids in the home program at home. Translated at home. The other things that we think were really important about the program were that it was done in a park. I think you mentioned that at the start, in outdoor parklands, which we were conveniently located right next to the two hospitals that we were working with, the two hospital sites. So Monash Children's and the Royal Children's Hospital both have parklands really close by, which were really ideal because they had not only soft grassy areas but different types of gradients to work on and different types of paths, so concrete paths and gravel paths as well. So those different sorts of what we might call like ecological settings, but then a kind of variety of different environments that the child can work on, we thought were really important. And then finally, it was a group-based program, and actually not finally, there's another component that I'll talk about which I think is an important part too. But the group-based program, we had, as I mentioned before, between 3 and 5 children in each group, and a study like this, we can't kind of disentangle which component was the most, like the key ingredient. It's actually probably a combination of all of these things that make it the program that it works. But the group-based program, what we'd seen in our pilot work, we thought was that there was really key to motivating the kids to participate and the way that they would work together on their goals.
Just with regards to the group as well, we know that those are all just, well, not even just the group, but all the components you talked about, we're seeing more and more like the trends that are supporting this in terms of a model and in terms of sustainability. It's something that we could then also translate into real life, real world practices, right? Yeah, absolutely. And that's what I think was from the outset really wanting this to be a program that was reflective of practice now and that could be translated into the settings in Australia. We have most children accessing programs and funding through the NDIS. So being able to translate it into those sorts of settings and contexts was really important from the outset. So making it really practical and feasible for therapists to do. Sometimes the group-based setting might not be feasible given they might not have 3 to 5 kids with cerebral palsy that they're working with that all have bike riding goals. But many of the other components could be applied to their practice. Sure.
As well.
And before we get into the results, because we want to make sure we have enough time to talk about that, I do just want to quickly just ask you about the dosage. And we know now, the clinical clinical guidelines for cerebral palsy are out. We've been talking a lot about Habitil in there as well. And we know that's a very intensive dose. We know that about that 90 hours. But that we know is a range of skills that you might be working on. And for this, the chosen dosage was also a lot shorter. It was over 1 week, home practice as well. What was the thinking behind making the dosage what it was, I guess?
So we drew on a lot of the literature from other areas that had done bike skills training. So in autism spectrum disorder as well as Down syndrome, there's been some published studies looking at bike skills training and having this sort of week intensive program, and that had achieved some really promising results. So we drew on that as well as some pilot work that we had done in the couple of years previous to the program and the actual trial program. We'd done a few pilot programs where we tested different sorts of dosages and came and landed on this as a dosage that was not only effective in terms of achieving the goals, but also we had found that there was acceptable to parents and that it worked well for families, that it was able to be done in an intensive period over a week within a school holiday period. And that was really important to families, that it was in a school holiday period because they didn't have to miss out on school, which often happens with other therapies. So that was why it was important. Well, that was some of the things that influenced why it was this shorter period, and also because, like you mentioned, because we were working specifically on one set of skills. And one. So we had up to 3 goals, but they were all related to bike riding.
And I think, you talked about, obviously, your parent involvement was a really important component of the intervention. And when we talk about, participation goals that these children might have, it's not necessarily in that intervention period that they're looking to, achieve the goal. It's in the context of, family or friends outside of that. So it's really important, I think, to highlight that the parent involvement is so crucial to be able to achieve those participation goals, in the real world, real life context.
It's nicely into results now, I think.
Okay, so Rachel, can you talk us through what you found immediately after that intervention period with regards to your outcome measures?
Yeah. So as you mentioned, our key outcome measure was Goal Attainment Scale, and from that we looked at goal attainment. And what we found in the task-specific group compared to the parent-led home-based program was that those kids that participated in those programs, the task-specific program, had 10.4 times greater odds of achieving goal attainment than those in the other program. So what that actually means in real sort of terms was that 24 of the children that participated in the program, the task-specific program, achieved their goal attainment compared to 9 in the home program.
Right.
So that sort of demonstrates the difference between the groups. So really showing that specialist physio-supported program is really beneficial for these kids who have bike riding goals.
That's wonderful.
Yeah.
And then what we found also with some of the other outcome measures was that we found that the kids had higher self-perceived bike riding competency. So that we used a motor skills competency measure, and a particular item of it called the bike competency item, and it was looking at how competent kids felt with their bike riding, and they had 4 times greater odds of feeling a high competency of bike riding compared to the kids in the other program.
Yeah.
With the other outcome measures, we didn't find any evidence. Well, we had sort of like trends towards a difference, but we didn't find any evidence of a really strong difference between the groups, which in many of them we weren't expecting that. We were interested to see if there were differences. One of the groups that were outcomes, that we were a little surprised that we didn't see a difference, but it kind of makes sense that we didn't see a difference given our type of analysis, was the bike skills checklist. We didn't find a difference between the groups at either time point. But when we looked back at our baseline results, what we found was that, and the baseline outcomes, I should say, not so much results, but the baseline outcomes between the groups was there was actually quite a higher level of bike skills in the comparison group or our control group compared to the intervention group at baseline.
So what about 3 months? Did you notice what were the things that you found at the 3 months? What were the main outcomes that you saw there?
Yeah, so at the 3-month period, we found that goal attainment had been retained, so that those kids still were achieving their goals with greater odds than the than the parent-led program.
Right. Yeah.
And that was probably around 4 times greater odds at that time point. But we also saw that there was a higher level of involvement in bike riding that was reported by the families compared to the other programs, to the parent-led program. So that was a really interesting thing for us to see. We weren't sure if it would, because the program, while we looked at activity and participation goals, the makeup of the program was really more focused, and the kind of key things like that task-specific, the motor learning program, the key components of it were really focused on activity level goals. So we were quite interested to see that there was a difference in the groups for involvement in bike riding at that 3-month time point.
Yeah, that's really encouraging, I think.
And I think it does talk a little bit about dosage as well. There's a difference in dosage, obviously, with when you come into a physio session, you're there, it's 2 hours. It's very focused time as well. So I think it does bring in that part of it. Yes, by having something to go to. I think we all sort of feel that way. Like, I don't know, going to the gym versus doing something by yourself. If you're going somewhere, you're dedicated to that task, you're focused on it.
There's a bit of accountability, I guess.
And
focus in what you're doing.
And doing it in a context where there's other people, you know, it makes sense to then feel more confident that you might be able to go out and perhaps, you know, engage in activities with other people. So that's, you know, improving confidence and competence. They're such huge things in this population that we work with.
Yeah. And particularly, in psychological research, we know that if people feel more competent, then they're more confident and more likely to perform that skill more often.
Yeah.
So, yeah.
And were there any just practicalities now, knowing those results, which are really exciting? And I think, as therapists, we can work towards that, knowing that kind of model. Is there many equipment adaptations that you need for bikes for children classified within GMSS level 1 and 2?
Mm-hmm. Yeah. So one of the things that doesn't come out in the paper because of the word count was some of those little modifications that we actually did. They were very simple to do, and it's included in one of the supplementary tables. I think it's supplementary table 1. There's a bit of a outline of the sort of more detailed components of the intervention, and talks about the two kind of key things that we used as a little temporary modifications were hand grips or wrist straps to support the affected arm to stay on the handlebar, and also some foot straps too. And for most of the participants, it was just simply using some felt strapping and Velcro for day, say usually the second and some other third day of the program, when we were working on the pedaling to support for the foot straps, for example. So we would use those temporary modifications just for that couple of hour period. If the child was struggling with keeping their foot on the pedal, and so we could kind of take the focus away from having to work on the foot on the pedal so they could get the idea of pedaling. And then we often then removed it. And then once they've got the idea of pedaling and balancing, then they could focus on actually keeping their foot on the pedal. So they were typically very sort of temporary modifications using that very basic materials and very inexpensive materials. But there were probably about 3 or 4 children in the task-specific group that we recommended and organised a couple of ongoing modifications, so like that wrist strap, and also a couple that ended up with a toe grip. A toe holder. So like the toe grip it's attached to the pedal.
It's so simple and easy to purchase and get yourself, isn't it?
Yeah. And great that you've included all that information in the supplementary files for the paper as well. So that's really useful, I think. So Rachel, I mean, we could talk to you about this for much, much longer, but we'll probably wrap things up here with a final question to you around this work and what your main recommendations for future work in this area might be. Where do you see the main focuses being?
Yeah, so there's a couple of things that I really am keen to explore further, and we are doing some of the work in the area, or and encourage others to look into this as well. And that is really looking at bridging this the gap between the bike skills program and then continuing with community participation in community-based sports and cycling that we see. So we had some promising results looking at involvement, but we still see amongst not only cycling but other sports and other skills that kids work on with physios, that they get a really positive experience and learn really great skills, but then actually being able to apply that in that real world setting sometimes isn't the focus. And so kind of what we're looking at now with some of my postdoc work is a program called CycleLink. And so it's linking these cycling programs with community-based opportunities. And so we're working with in Victoria here and hopefully more nationally in the future, but we're working with Cycling Victoria, bicycle networks and councils and other community-based providers or organisations that work in cycling to try and build those more supportive and inclusive environments, so that these kids who have done programs or work with therapists on these beginner skills can then go into programs that support them to participate in an ongoing way. Because with my trial, we only looked at 3 months. It's really looking now at what they're doing, years later as well. So that's where it's sort of, I think some of the next research, that's where I'm really excited about doing work in. And then the other area I think would be interesting to look at was that, there were some kids actually that did really well with their families in the program. There were 9 kids that achieved goal attainment with working with their families. So looking at some of the results and seeing, well, actually which kids would benefit more from the program and which ones actually, you could say, have a try. Here's some basic things that you could do with your family, because that's a really empowering experience for the family.
To look at that.
Unpacking that some more. So interesting.
Because I think that, we've seen that they're really beneficial, but not every single child with cerebral palsy will require it. It depends on their individual circumstance. So sometimes with trials like this, you can kind of get caught up in the headline, but I think it's important to still consider actually it might be a really important experience for the family to try at home, and a bonding. You guys are just talking about learning with your families, so like to have that experience as well might be important for some families too.
Definitely.
Oh, look, I think that's so wonderful. And that leads us really nicely to wrap it up now to the next segment. A very popular segment, as we're always told, is Tell It to Ed. Now, this is the 60-second pitch to the common man, Ed. And Ed is our producer, doesn't have a background in child health, and he's here pushing buttons and making sure everything works and that we can record this for you. But he's been listening in. So now it's your turn, Rachel, to give a 60-second summary of your research, and Ed will in turn have an opportunity to ask one question. Take it away, Rachel.
Okay, so this study looked at a task-specific, a program that was focusing on bike riding, where physios led kids that had cerebral palsy and their families in a program that was done in the school holidays, and we looked at how good it was for achieving their bike riding goals compared to a program where parents worked on the bike riding goals at home just with their families. So this program was done with, as I said, in school holidays with physios. It was in a group program, and what we found was that program was had the kids who participated in that program had around 10 times greater odds, or were 10 times more likely to achieve their goals relating to bike riding, like learning to ride a bike for the first time or riding at the school camp, than those in the other program.
Oh, lovely summary, Rachel.
Beautiful.
Well done. Really good. All right, Ed, are you ready? Your turn for a question.
I'm kind of ready. So obviously you've covered quite a lot of ground there, and I think one of the interesting parts was the whole dosage thing, and then you mentioned like a tenfold improvement between I guess the sessions that are done with the experts, the physios and the allied health people, and then a home program. And I was going to ask a bunch of questions because my mind kind of goes off on little tangents as I'm listening to these podcasts. But I guess my question is much more generic, for want of a better term, is there something like incredibly special about cycling in general for kids? We talk about like learning a skill as an adult, and you go, well, it's like learning to ride a bike, and you kind of never forget that. And is it some combination of like the balance, the physicality, the health aspects of stuff? Is the actual task of riding a bike, is cycling like a really important skill to learn for everybody? And is there something there that gives that longer lifespan, the like better results in the longer term because it's cycling?
Ooh, good question.
Yeah, well, I think that touches on what I was talking about to begin with, and that's about how when we're working on activities and in therapy that are meaningful to families, then we will see better outcomes. So, riding a bike or a scooter or something that's fun for kids compared to, say, doing sit to stands or other types of maybe what might be kids might think it's sort of more boring types of therapy. When it's meaningful and can be thought about in the context of their lives, then I think that's where cycling kind of comes as into its own as a really important activity that kids do that's physical, not only can be done with friends and family, but also is important skill to have into the future with things like commuting, getting, I typically ride my bike to work when I'm working in the office. If you think about all the F words, and I love coming back to the F words and framing it with that, so I think your listeners are probably familiar with the F words.
Yeah, we like the F words.
But usually finish on F words.
Oh, good. Is that it really ticks all those boxes. So when I'm talking about that, Ed, is the thinking about when we're thinking about interventions for kids and not only interventions, but checking in with kids to see how they're going with life, it's important to look at those F words. And so whether it's fun, if it involves fitness, so cycling is a physical activity and, getting on a bike will contribute to your fitness. Family, it can be done with family. Future, it's something that's a skill for the future. It will hopefully, can contribute not only to positive health behaviour in the future, but those things like commuting and other types of, bike tourism. You can do all sorts of things on a bike. And then, of course, function. And, it's an important part of function and is a functional activity. So I think it really ticks all those boxes with the F words.
Nice question, Ed. Brings us back to the F words again. Well, we do need to wrap up this lovely podcast. Remember, to all of our listeners, you can have a look at our run sheet notes on our website, researchworks.net, and there's a form there that you can fill out so that you can keep a record as part of your CPD. But for now, thank you so much, Rachel, for being on the show. We've absolutely loved having you here. Thank you for your time.
Thank you so much, Rachel. It was great to talk to you.
Yeah, thank you for having me, and it's great to have this opportunity and great work on the podcast.
Thank you.
I'm a big podcast fan, so I'm excited to take a listen and also to be on a podcast. It feels very special. So thank you.
It is really cool. Well, to all of our listeners for now, thank you so much. We'll talk to you again next week. Bye.
Bye.